So AML's a rare disease. It's about maybe 2,000 patients a year here in Australia, and the subtype that we're interested in, extramedullary, is about 20% of that. So we're looking at maybe 400 patients a year, which seems like a lot. It seems like it should be pretty easy. The trial is only 30 to 50 patients, but not many patients actually participate in clinical trials.
One of the subtypes of this acute leukemia, which is a very aggressive blood cancer, is acute myeloid leukemia, and can be really, really aggressive. There are very few treatment options available, and this particular trial actually looks at a subset of people who have worse outcomes than the usual acute leukemias. And it's called AML-EMD, or extramedullary disease, which means whilst leukemia generally is present within bone marrow, which is the factory where all the blood is made, this particular type of leukemia actually presents in other spots outside the usual factory, such as the skin, solid organs, and even the brain.
50 years ago, where AML was a death sentence, if your doctor told you that you had AML, it was basically you had less than 2 months to live, and it was basically go and sort your will out and say goodbye to your family because you're going to die.
It tends to be very aggressive and very difficult to treat, so this particular trial is of interest to the community of blood cancer specialists, as well to the patients, because for the very first time we are looking at a trial that targets this group, which has a really, really poor outcome.
I was diagnosed in January 2020 with AML leukemia. I've been through a bone marrow or stem cell transplant, which I did just under 2 years ago. Well, I hadn't realised quite how rare it was, but it's serious from the point of view that leukemia affects a bone marrow disease, which of course affects your whole immune system. And you're in a situation where it runs down your immune system, it runs down your blood cell production, and in the end you just basically, can't produce fights against infection, against common colds, things like that. So if, like normal infections, it's like going back to the pre-40s where there was no such thing as penicillin. You could turn around and get a scratch and die from septicemia.
This particular trial uses a redeveloped drug, Xantrine, which has been been brought to the clinical arena now by Race Oncology, and it's used in combination with either the standard chemotherapy backbone or with an oral drug called Incovy in slightly different scenarios. But basically both groups of patients, whether they're suitable to receive more intensive treatment or less intensive treatment, are catered for, and there are no clinical trials at the moment anywhere on the globe that focuses on this group of patients. So a rare disease in a rare group of patients, but this drug in some of the modelling and previous trials has been shown to be of benefit to this subgroup, and we therefore believe that by having a broader, bigger trial across the globe exploring this concept will actually lead to better outcomes in these patients.
The first thing is to prove out that this FTO opportunity actually works in people. So we know it works really well in mice. There's a whole bunch of circumstantial evidence that suggests it will work in people, but nobody's yet proven, and that's because nobody's yet had a drug that can be tested in people. So we have the first drug that can be tested in people, and so we'll actually prove out this hypothesis, that if that happens to be the case, then things could be really exciting.
If you look at how we used to approach treating leukemia in 10-20 years ago, it was like a shotgun approach. So you basically blasted everything in sight and tried to completely knock the leukemia on its head. We've understood over the course of time that this approach doesn't always work, because there are resistant cancers which don't get shot away and will always rise from the dead.
So obviously we hope that all patients respond really well, but of course we have to be realistic. Not every patient responds to every drug. So we'll be certainly studying what are the differences between patients that do respond versus patients that may not respond as well.
It's rare that you happen to be the leader in a totally new space in oncology. So totally new areas don't come along that often in oncology. It's not too difficult to find a new target for oncology. There's lots of them out there, but many of them are very narrow, very specific to a subtype of one cancer. We happen to be really lucky to have a target that's really widely found across pretty much all cancers. Every cancer that anyone's looked at has found that this particular target's involved in at least some of the cancers. So that creates this opportunity, a massive opportunity, not just within one cancer type, but across all the cancer types that are out there.
Oh, look, I think, to be honest with you, probably the enthusiasm of the team, the enthusiasm of Daniel, and his passion about the drug probably hooked me in to start with. And then when you start looking at the biology of it and the previous trials that have been done on this drug, you know, it really was a no-brainer for us. It's exciting biology, it's exciting potential for patients. So yeah, there was no way I was going to say no.
Clinical trials are important because without them you just don't get the development. And if you don't have the development, then you don't have progression. And when you think about it, you've got situations like it was only 20 years ago, you know, like the treatment that I got didn't exist. 10 years ago, the treatment I got didn't exist.
The ultimate aim of this clinical trial is to improve outcomes for all patients with this type of leukemia. What do we mean by improving outcomes? It means less visits to hospital, more leukemia-free time, less infections, and better quality of time with family and friends. So it's a pathway to curing this type of leukemia, but along this journey we hope that it'll bring benefits to individual patients and the community as a whole.
The FTO opportunity is a massive opportunity. It's an opportunity that is as big as they come in oncology. Oncology is a massive area. If you look at some of the big classes of drugs that target something like the immunotherapies, they're over $50 billion a year. Kinase inhibitors are another big class. They're like $30 billion a year in sales. Oncology is a big market, and when you happen to be the first in a particular new market, that can be really significant. Investors should be interested in RACE and this trial on the basis that could be a massive opportunity, and if it does, then shareholders will do very well. But also a lot of shareholders in small pharmaceutical or biotech companies are interested in seeing the treatment actually progress. It's more than just an investment. They're wanting to see patients benefit. They're wanting to see Australian companies do well. And so it's, you know, if you make a lot of money out of it, that's fantastic. But it's investing and doing good at the same time. So you could donate money to charity, or you could invest money in companies that are trying to bring drugs to market. So both ways of actually achieving a good outcome, I think.